All right, perfect. So I have started recording, and Dr. Miller, take it away.
So I'm Alison Miller. I'm a family practice doctor, and a few years ago, I started treating addiction in primary care. So familiar with pain and addiction. A lot of my patients come in with pain, and I see a lot of your patients with uncontrolled pain, and kind of trying to figure out how to decipher, who should have opioids and, the safe way to prescribe. So you can keep going, the slides. I don't have any disclosures, but those, yeah, exactly. So I think it is really complicated on how to treat pain. There is a lot of different modalities. Obviously, here are a bunch of evidence-based modalities that our patients do not use. I know that this topic is about specifically opioids, and I know you've had a lot of lectures recently about safe prescribing, but I really kind of wanted to focus today on who we should prescribe opioids for and who is appropriate. And once we figure out who is appropriate, then how to do them safely. Next slide. This cartoon always makes me chuckle. There's like the long line for pills and surgery, and nobody's interested in lifestyle changes. I think we are all caught up in this. It's not just the patient's fault. There is EMR and having to see patients every 15 minutes. There's just not a lot of time for those lifestyle changes. So, patients want to get better quickly, and pain is a big problem. So, we are working on trying to fix that and educate patients, and hopefully this lecture series helps that. Okay, next slide. So this is kind of where I wanted to kind of focus some of my time on before we talked about safe prescribing. Before we even decide on who is going to be prescribed an opioid, you kind of have to think about what kind of pain is it? So I think if somebody comes into my office, let's say that they just have had surgery and you gave them a great 6 days of narcotics, and they're coming in now to see me wanting more pain medicines, and their pain is not controlled. I kind of try to think of pain in 3 different ways. So it's the nociceptive pain, nocioplastic pain, and neuropathic pain. And then, of course, there's the mixed one. So the nociceptive pain, that's the inflammatory pain. That is coming from an acute injury. So that could be from surgery. It can be from some type of sports injury, a fracture, acute low back pain. It's pain that you can actually see. So then the next type of pain is the nociplastic pain. This is the type of pain where these patients have had chronic pain for a long time. It's tissue injury. It's damage that you cannot see. So the way that I kind of think of like nociceptive pain when I'm talking to patients is that I think that if you take a hammer and you accidentally injure your thumb, you jam your thumb with the hammer, the treatment for that is to take your other hand and rub your thumb for 5 minutes and shake it out, and then it goes away. So let's say that a year of rubbing or a year of shaking your thumb, then the problem isn't that you hit your thumb with the hammer. The problem now is the rubbing. And that's kind of how I kind of talk about chronic pain and the injuries that kind of come from that. So this is like the fibromyalgia, the complex regional pain syndrome, the chronic low back pain. We do have a lot of patients that are on opioids in this class of pain. And now we know that for chronic pain, opioids do not have a role. But these patients were put on years ago, and it's really a huge challenge in discussing weaning people off and how actually their pain could be worse with using the opioids. Patients just do not understand that. And they're fearful of going off the opioids. And then the final class of pain that I think of when somebody comes in is the neuropathic pain. Is this a nerve pain? Is this radicular symptoms? Is this post-herpetic neuralgia? The common one that we see in our office are the neuropathies and the diabetic neuropathies. So like thinking of these three classes of pain medicines helps me think of who should have opioids. So you can go to the next slide. So obviously that chronic nociceptive pain, the fibromyalgia pain, no opioids. So right away, if somebody is coming into my clinic and they're talking about their pain and talking about opioids, we go into alternative types of treatments, which are, much bigger than the scope of the practice. But for acute pain, and I do think short-acting opioids are appropriate, as well as the neuropathic pain, and possibly then switching to long-acting opioids, which we will talk about in the future. But just knowing that nociceptive pain and the neuropathic pain are the only two pains that should require opioids. Okay, next slide. So we've decided that we are going to begin opioids on a patient. You always want to give the lowest possible dose. You always want to begin with the shortest acting. Patients usually come in and they kind of tell you what they want. I usually start with hydrocodone. It is a lower dose morphine equivalent than the oxycodones. I've learned a lot over the years to really stress with patients that this is how much you're getting, this is how many days you're getting it for, you can't take more than prescribed. I add that right away to like the patient instructions so they know that, after 48 hours, if they took their 7 days of 7 days of opioids, then they're not getting any more sooner. And that's also like a concern for people who are overusing when that happens. I always talk initially about when we're starting on opioids is talking about functional goals, and we'll get to that as well. I am like a big naloxone prescriber. However, I don't feel like there is a huge role in prescribing naloxone for acute pain. It can't hurt, but I hope that I don't typically do that, but it can be prescribed as well. Anybody that I have on long-acting opioids, as well as them giving prescriptions to, I am making sure that they have naloxone at home and educating them on how to use them. I always want to talk about the side effects of opioids, specifically the constipation, that having a bowel movement could even be more painful than actually the opioids. So to let them know what they're getting into by starting these medications. And I never initially prescribe more than 1 week. I do feel like they have to either send me a MyChart message, or they have to call the nurse, or they have to follow up and return to the clinic. All right, next slide. So, patients with pain and that you're prescribing the opioids, you obviously want to see them very frequently. And this is where the importance of the functional goals are. This has really changed my whole practice in prescribing opioids. I used to be really angry when patients would come in and they'd be on opioids and I didn't know what to do, and I felt really overwhelmed that I was not really helping them. But if I come up with like a functional goal together with them, or we come up together, for instance, I have a patient that for the past year, she has really bad social anxiety, and she has been wanting to go to yoga. And that was her functional goal. And just recently when I saw her back last week, she got to a yoga class. But it took a lot of encouragement, and even to the point of me like reviewing what she would say to the yoga instructor when she like first walked in. So, but she got there, and it felt really rewarding for both of us. So patients can do better and make progress. You always want to monitor for breakthrough pain, and we're going to talk about that in the future. Always want to talk about side effects, specifically, again, the constipation, making sure that they stay hydrated, drinking enough fiber. So fiber and water, I've noticed that are where I see the most improvements from constipation related to narcotics. On the screen for endocrine function, as needed, That's an issue a lot of times in people who are on this long term because of the hypogonadism, the low testosterone. People have decreased sex drive, difficulty with erection, and weaning them down off of the opioids does help that. Reporting the adverse effects and to implement opioid rotation is something that I do often. So in patients where they feel like they are not making progress, they're not improving on opioids, I will change it to a different opioid. And if you ever are going to do that, I do lower it by 10 or 20% the dose. And I do monitor that, change the dose through using the morphine equivalent. Next slide. So obviously, in EPIC, you cannot sign an opioid prescription without checking the PDMP. Who to do urine drug testing. So patients that are in acute pain and they're getting 1 or 2 prescriptions, I don't typically do urine drug testing. But if they're requesting refills and wanting more than prescribed, and I am more aware of that, and I may do urine drug testing and then assess, obviously, for a substance use disorder and opioid use disorder. You do have to be honest and open with patients in telling them that you are doing urine drug screens, that you are concerned about them using more than what's prescribed, and why you're testing them for that. You want to make sure that they're taking the right amounts and taking the medications regularly. So I think it's a really hard decision on, when opioid treatment is no longer necessary and when is weaning appropriate. I kind of try to talk about that now when I'm starting somebody on opioids right at the beginning. When I start the opioids, I'm saying to them, this is, you have an acute low back pain flare. You should be getting better in 5 to 7 days. I am going to give you 1 week of narcotics. I will not give you any longer. So having that conversation right at the beginning really helps them to know that this is how much they're getting from the beginning. The challenge, is a lot of times in the patients, especially post-op, that they've received the opioids from the surgeon and now they're coming to primary care wanting more narcotics or pain management. In situations like that, I really encourage primary care doctors to contact the surgeon and find out, what is the typical pain pattern for somebody who has had their tonsils out or whatever it may be. Should she still be in pain in 14 days, 2 weeks later? No, if that's not the most common thing, it doesn't mean she doesn't still have pain, but to think, is this more still just healing, and what other modalities for pain management that we can give? Next slide. So sometimes, it is helpful to move patients to extended release opioids. I try as hard as I can to not keep people long-term on short-acting opioids. It is a challenge. Sometimes it's from insurance companies. Long-acting opioids are more expensive. So oxycodone and hydrocodone are $5 copays. They're cheap. And, nobody's going to want to do an MS Cotton where it's a $30 or $50 copay. So it is a challenge to switch to people for that reason. I do try to stress the importance that, about how pain works, and that if you are taking a long-acting pain medication, it keeps the levels around longer and you're not dropping down and your pain is not getting back to a 10 out of 10, and to try to explain that steady state with them so they know what to try to get them to buy in. So again, when I'm switching to somebody with long-acting and I'm switching to a different medication, I will lower the dose by 10% by the morphine equivalent until I feel like they're not having as many side effects. Next slide. So this is my final slide. I think of this a lot in my head. I've always thought of the pain when patients come in for follow-up as the 4 A's, but now I see that there's a 5th A, which is affect. So the first A, in my head, when I see somebody that follow-up in pain, this is kind of like where I am, like with my SOAP note. Is the pain working? Are they getting analgesic, are they getting pain relief? 2, is their activity improving? Are they improving their function? What are they doing? What are those goals? Are they meeting those goals? And to actually hold patients accountable. I use my sticky note in my Epic all the time just to put in the quick functional goal of where I'm going with that patient so I can remember. Just making sure that there's no aberrant problems, meaning that they're taking as prescribed and not getting early refills, to go over that with them. And then checking for any type of side effects, adverse events. And then I guess their affect is the new A, which is their mood. So for the aberrant behavior, in primary care, if patients that are on long-acting opioids, we do have them sign a narcotic contract if we are going to be prescribing regularly. It is very, it's from 2012. I wish it was better. It does not state functional goals. It definitely could use some improvements, but that is the UW Health one that we all have to use. Typically on patients that are on opioids too, I do check urine drug screens yearly. And sometimes more often if needed. So those are the 5 A's for pain. And then there's the 5 C's for people that you've concerned about with abuse. So pretty much with the abuse, like if somebody is having negative consequences with the opioids, you really have to think of abuse. So they've lost control, they're using it compulsively, craving, continued use, and it's become a chronic problem. So those are the patients that I have been seeing over the past 5 years in my primary care office more and more, and happy to see anybody that you have seen that may fit that role. In my clinic here, we do office-based buprenorphine and naltrexone. About like 40 or 50% of my patients that I see have addiction. So it's been a really change in my career and it's been super fulfilling for me. So that is it.
Awesome. Thank you so much.
Yeah.
I'm going to stop sharing here. Let's see. I've just put in the text box again for our live participants the code to enter for credit. That was an amazing talk, and I think so illuminating for me as a surgeon who doesn't see the patients that go to the PCP with requests for additional narcotics. I have a bunch of questions, but let's open it up to our participants first. Questions from you folks, and what are you seeing in your communities, and what resources do you have in place to start manage these patients who do come back from surgery or injury asking for more pain medications? Again, feel free to use the text box or to use your mics if you've got them. As we wait for people to type, can you talk a little bit about that transition in your practice, and like from being I assume sort of more general family practitioner to now focusing more on chronic opioid use disorder, and what's the waiver process like, and how has that sort of changed the way that your daily life works?
I am so happy to talk about that. So, you know, I am like mid-career family medicine provider, and I've been involved with UW Health Wellness and improving burnout and fulfillment in my career. And I kind of wasn't really going anywhere with that. And I realized that it all kind of like hit at the same time, that I was just like looking for something more and different in my life. And realizing that this buprenorphine treatment really changes people's life for the better. And as a family medicine doctor, it really trickles down to their whole family, their kids, their partners. So I just think it goes along with everything that I believe in. So it's really easy to get your waiver. It's actually going to be even easier very soon because you're not going to have to take a live training. Right now, you have to do a 4-hour live training and a 4-hour online follow-up. So it's 8 hours of training. Soon the live training is going away. I would say probably in the next 6 to 12 months, and you're going to only have to do the 4-hour online. So then with the waiver, you can prescribe buprenorphine. I would say that the easiest part of treating these patients is just the prescription. There's so much more than that. In my practice, like I probably am working harder than I ever have, but feel so much better about my job. So it's been really cool for me. I don't have a ton of support in my office from it. I don't have a lot of access to therapy and counseling, and I'm really using the local community for that. Things are evolving at UW Health. They are working on like the hub and spoke model, which came out of Vermont. So there is going to be more access and more support. We're piloting a program starting in March of 2020, but change is slow and it's hard and it's going to take some time. But anybody can get their waiver. So I encourage people to get their waiver.
And with the waiver, then you can prescribe buprenorphine, and that lets you sort of, give a medicine that you otherwise couldn't give to these patients with chronic opioid use disorder. But it's not as simple, right, as just take buprenorphine and you're no longer addicted to opiates.
Exactly. I mean, addiction is like a chronic brain disease. It's like a chronic illness, just like diabetes or high blood pressure. There's something in patient's brain genetically or trauma as a young child that has changed the way that they experience reward. And therefore, they will use medications, alcohol, meth, cocaine, whatever their people's drug of choice is. It doesn't really matter that it's opioids, that everybody has a different drug of choice, but really the disease is the addiction. And so buprenorphine kind of calms that part of the brain that's connected to the opioid problem, so people can start making better choices and better decisions using that frontal portion of their brain. And that just takes time to build that, and lots of therapy and lots of counseling and lots of support. I'm seeing these patients really very frequently. So right now, if like somebody comes in and is using, typically the patients that I would have to say that do well in primary care are patients that are more abusing oral opioids like oxycodone or hydrocodone, and either crushing it or taking it more than what's prescribed. I have struggled with patients who are really using a lot of IV heroin to be treating them in my primary care office. I have not been as successful with the buprenorphine. Those people need a lot more support. I try because there's not a ton of access. And, I think by starting to see me, I can help them connect someplace else, but they don't do as well. But we're starting to study all of this, so it's going to be really exciting.
That's so cool. Catherine Lee is on the line. She is actually works at UW Health and is helping to develop our chronic pain guidelines. And she says one of the topics that came up as a challenge for primary care doctors was how to refer a patient and when to refer a patient to pain medicine. And that was actually a question I had as well. Like when do you say like, this is not for me, this is for pain?
I mean, I think that is a struggle. And, pain medicine at UW Health is procedure-based. It's not a medication. There's not really a lot of medications that they give or talk about like just health and wellness. There are more health and wellness stuff that is happening. There's actually cool pain health and wellness groups that are starting at the American Center that some of the family practice doctors are doing. But typically, patients that symptoms have been going on acutely for now have become chronic, had acute pain and now lead to chronic pain. After just a few months, I will try to get them in early to the pain clinic, because if you can stop those feedback loops, stop that rubbing of that thumb sooner, I think it's like you actually have better treatment. It is hard to get into the pain clinic. It's not like, patients want instant relief. You know, then having to wait 6 or 8 weeks also to see the pain clinic is hard. And I think there should be better communication between the pain clinic and surgery, primary care. Learning how to figure out how to communicate better with them could be a great thing, you know, if this is something that you're working on.
And, you know, I don't want to dominate this conversation, but I do have like a whole page of notes.
Okay, yeah, go for it.
But, so, you know, please, guys, feel free to interrupt me, or like if you type into chat, like I'll prioritize your questions. But I do think that question of like how you coordinate with surgeons is so interesting. Like from my perspective, right, we do an operation, we're increasingly less likely to prescribe opioids or long duration of opioids. But I remember when I was a surgery resident, you know, like we would look at how many opioids people had taken in the past 24 hours. We would multiply that number by 30 days and we would write them a prescription for, you know, 250 Dilaudid tabs and send them onto the streets of Seattle. And I guarantee that there are people who are feeling the effects from that to this day for me, but that was just kind of how we did it. And we never heard back, or, you know, and even now, like I don't hear back from primary care folks about patients kind of representing to them. And I think, you know, before I started sort of exploring this, I lived in happy ignorance thinking like, oh, it must be that if my patients aren't calling me for more pain meds, they just don't need more pain meds. They're fine. But I think much more likely they're presenting to their primary care physicians with these more chronic pain complaints. And clearly we need to do a better job about communicating with one another about, you know, what our expectations are and what you guys are seeing as the downstream effects of our prescribing.
Yeah, I mean, I you know, send messages all the time to surgeons. Like, I mean, I think the best way that I've been successful is like the re-patient not in chart, to say, you know, I tell the patient that I'm going to be contacting your surgeon to talk to them about, you know, what was going on. And I mean, you guys are really good at responding back in 24, 48 hours. And I'd let the patient know that I'm going to reach out to you and we're going to come up with a plan with this. Do you feel like that re-patient not in chart is the appropriate way to contact you through Epic? Do you guys use that?
Yeah, we definitely do. I think that's a good way to do it. I would hope that like other primary care folks not in our system, or, you know, like if they just don't feel as comfortable reaching out to surgeons, I speak for the surgeons when I say like, we love to know what's going on with our patients after we've operated on them. And at least, you know, for every surgeon I know, we're anxious to get those messages, and we're not anxious to pawn it off on the PCPs and have them, you know, just fix it on our behalf. So like, definitely, like we want to be involved in those conversations.
And maybe I'll pass that information on to some of the primary care doctors, because I know people like try to page the surgeon or call, you know, whoever's on call, and that's ominous. So
it doesn't work well. Like we're just too many places at once. Yeah. Yeah.
So I can pass that information on.
Yeah, for sure. What's your approach to these patients? And my experience with this is mostly limited to sometimes the comments we get when we promote these events on social media. We'll often get very angry comments from people in the community who say, you can't take, you know, you're trying to take away our opioids. Opioids are the only way that I get through the day. Like you know, there's a real pushback against these efforts, you know, and we're not trying to eliminate the use of opioids. We're trying to sort of moderate their prescriptions and use them where they're best indicated and where we know they work. But what's your approach to patients who say, I need my opioids, you can't take them away from me?
So, I mean, you know, just like how you gave the Dilaudid post-op, I mean, I have patients on, you know, 90 morphine equivalents, multiple patients with fibromyalgia, and have really no tissue injury, no damage, you know, are, you know, not meeting their functional goals. You know, and trying to wean those people, it's a real challenge. I mean, these people have been on opioids for, you know, 20 years. You know, I start with one at a time. I really try to wean people down under that 50 morphine equivalents. You know, I talk to them about opioid hyperalgesia. I talk about, especially in elderly patients that are on opioids, making sure, you know, to know that you have an increased fall risk, you have increased confusion, you have increased risk of, you know, constipation and mental status changes on this medication, to try to have them buy in. And then I really, again, also like talk about that safe prescribing. You know, most people that become addicted to opioids are not being prescribed the opioids. They are getting them from family and friends. So, you know, you think that maybe they're getting them from like a drug dealer, but they're not. So the opioids that are being prescribed from grandma, that's the concern that I have, is keeping them away from teenagers and that 18 to 25 age group that's the highest risk for opioid use. So it's really educating the patients who are getting the opioids to making sure that they have a lockbox, that, you know, about med drops, about, you know, if they're not using their medications, like how to deposit of them. I mean, med drops save lives. So that's a really important component that I think is not really being used. If that's, I don't know if that's the right answer.
No, absolutely. I mean, I think that like that question of diversion and like, you know, you write a prescription and how many of those, you know, what we're increasingly finding out is that people after most operations take none or maybe one or two of the 30 or, you know, 100 pills that they're prescribed, and then those find their way into the community in all kinds of ways, right? So that question of disposal. And the other thing that I think has been really illuminating to me is some of the work that's been done in the School of Pharmacy here, just looking at whether people are aware of whether the medication that they're taking is an opioid. I think people are familiar with, you know, morphine and maybe OxyContin, but I'll be honest, I didn't realize that tramadol was an opioid until late in my training, because it didn't have sort of the classic sound of an opioid medication. A lot of times people are taking medicines and don't even know what they are. Yeah,
that's a really good point. Or, you know, taking the opioids with benzos, which, you know, are other medications that increase your risk of respiratory depression, and really, you know, doing that, working on that polypharmacy issue as well.
Got a question from Catherine. If you have a patient who's on chronic opioids and seems like a candidate for weaning, what do you do if the patient refuses to wean? And how do you do a taper? How do you manage that taper schedule? And I'd also be interested, as part of that, of knowing about your opioid rotation, which I'd never heard about doing before.
So I guess like there's two things. Like a lot of the patients that I see at my clinic are patients that, you know, who like maybe one of my colleagues is seeing, and they've been giving them narcotics, and then they have, like, they've been giving them oxycodone, so then they have hydrocodone in their urine. And they didn't realize that they really have been buying things on the street and have been struggling. So that's where, like, having the waiver for me is like just another tool to be able to treat chronic pain, because buprenorphine it's a partial agonist, so it still binds on that mu receptor. And, you know, you just dose it instead of once a day for addiction, you dose it every 6 hours, and that can help you relieve pain. But that's actually easy. And patients do really well when you find out that. But then what about the patient that's on like 300 morphine equivalents, and there's a new patient that has come to your clinic, and you then have to slowly wean them? You know, we all do it. It's a struggle. And I think setting up specific guidelines on how much you're weaning, you wean slowly. It could take a year. I had a new patient recently, about a year ago, and he was on 300 morphine equivalents. He's now on 150, but it's been a year. So it's going very, very slow. It's like 1 pill a month for some people, because they're so fearful that they're not going to be able to function, or they're going to go into withdrawals, or, you know, so that, you know, that's a whole other topic that I didn't really even bring up. It's like the dependence and tolerance that these people get. But by doing one a week, you're not going to go into withdrawals.
Cool.
But
Oh, go ahead.
So no, I'm just saying, like, so usually I use that morphine equivalent calculator, like in front of the patient. So, you know, you Google like morphine equivalent calculator, you put in how much they're on. So let's say they're on like, you know, 90 morphine equivalents. We talk about, okay, you know, by next month you need to get to 80 morphine equivalents. So that means I have to take away 2 pills. So I make it very much like a math problem and really simplify it. And, you know, to explain that this is being on the 50 morphine equivalents or less is like what the CDC recommends, that this is what's safer. This is what's going to prevent overdose. And, you know, this is, your pain may be less. You may have improvement in pain if you decrease the dose. So those are the kind of things that I say to patients. It doesn't always work, and it's hard.
It does make sense that like giving them a real structure and being like, we are going to like do this in a mathematical, structured way, not just freewheel, like cut it in half every day until you're off, right?
Yeah, and I think it's like not fair for patients. This is what happens a lot. And these another group of patients that I see is that my doctor cut me off because I was asking for early refills, and now I'm going through withdrawals. Those are the patients that when they get cut off, they're like looking to buy things on the street. And those are the patients that sometimes then have to switch to heroin and have really high risk of their, you know, being fentanyl and overdose. So it's like patients that have cocaine in the urine. A lot of my partners here will just stop prescribing like high dose opioids all at once. And I actually think that's like, you know, our job as physicians to do no harm. And I think that's harmful. So that's a whole nother interesting discussion, but.
Absolutely. Can you talk a little bit about functional goals and like what those look like? I mean, I think I wrote down like such a PCP thing to do, to like have a functional, long-term functional goals, right? And I think in surgery, we're like, yeah, you get back to baseline or you don't. But like what do those functional goals look like that you're tracking, you know, longitudinally over time?
I mean, for everybody, it's different. I mean, I use like, you know, I'm not so great at motivational interviewing, but I'm working on trying to improve that. You know, I leave that up to the patient. And, you know, I say to them like open-ended questions, like, so like, what do you think you want to do? Like, why are you taking the opioids? Like, what do you want to improve? What's something that you think that you want to get better at? What's something that you want to change in your life? I let them tell me. And so like, they may say like, okay, I want to be able to play with my grandkids on the floor. Well, like, how are you going to go about doing that? You know, what are some of the things that are you going to make that do that, and set up like a timeline and how that's going to work. And then to kind of say like, you know what, if you know, after 6 months, if you're not meeting those functional goals, that's like another reason to have them like to talk about weaning. Like, you know what, these opioids are not working for you. You're not getting better. You're not meeting your goals. So it's a reason to help buy in on the wean as well.
That's so cool. I mean, and like having it be patient directed, right? That it's there's not like a single like list of CDC approved functional activities that you're working towards. It's like every patient's specific need is, I mean, it makes so much.
Yeah. It's really interesting, especially treating with this addiction group. Like, I would think the most common thing that like people would want would be like housing or job or money, you know. But that's not what people want when they want to become clean. They just want to feel normal. You know, they want to feel happy. Like, they just don't want to have all this baggage anymore. So I think it's really interesting to ask the patient what they want, because I think what we think they want is wrong. And it always surprised me. So
that's awesome.
And I just would also put another plug. It's like, you know, I think that everything is very medicalized, and like, I think it's really hard to always listen. And this is asking something specifically about something to them that means a lot to them. And it's really quick.
Yeah, that's so cool. Angela Bisa is a nurse practitioner in Janesville who's joined us, and Jessica Varnum is a family medicine doctor in Lancaster. If you guys have a sec to just, you know, use the chat function to just tell us, I'd love to know, you know, if there are dedicated programs at your place, or there are people with waivers who are doing this work. I think that'd just be really, I'd like to know kind of how widespread this sort of availability for PCPs is. Can you talk a little bit about naloxone, and particularly your thoughts, like we've been talking a lot here about the availability of community naloxone, and like how you can go to the pharmacy and get naloxone essentially over the counter. Do you see a role in that? Are you counseling your patients, about the availability of naloxone without a prescription?
I mean, I am a huge naloxone. I mean, I can't be doing this addiction thing and not be like a huge proponent of naloxone. So just to go back to your first question, I feel like I'm unique on what I'm doing right now. I am trying to get my colleagues and partners to kind of also try to get their waiver and do this. I mean, I think providers are very afraid that this is going to be more work for them. So they don't want to take this on. And I think that's an issue. I think UW Health is working on trying to figure out like smart sets and having a nursing role and having more counselors available and having better communication between, that's the hub and the spoke. So the hub would be like the addiction specialists, and the spokes are all the primary care clinics. So that's kind of like the wheel of a bike. So that's where we're trying to go. And I'm hopefully more primary care doctors will kind of do what I'm doing. But right now at my clinic, I'm the only physician. And there's been 2 APPs that both trained. And it seems like the APPs are much easier they seem like they're getting more on board. And I would have to say that the APP training right now for the waiver training is 24 hours, which I think is also going to go away. And I think it's unfair. So they have the same 4-hour online face-to-face and then 16 hours of an online training. I mean, I've listened to all the lectures. They're really good, but it is a lot more and seems ridiculous, but I don't make those rules.
Do you get to bill differently for doing opioid work, or is it just sort of counted as a standard visit?
So the way that I get paid is a little different, probably the way that like surgeons get paid. Like we get paid to take care of a patient population. So however many people, like I'm the PCP for like 2,000 patients. So that's how I get paid based on that number. There is a small like RVU component to it, but it's not not that much. So it's all based on just like RVU office visits. So I don't get paid differently.
Yeah, at least you're not getting paid. It's not reimbursed. Like you're getting supported to the degree that you're taking care of any number of capitated patients.
I mean, I feel lucky as a doctor. Like I get paid a lot of money. Like it's good.
Yeah. Yeah.
Yeah.
Those are sort of like the key things that I came away with from what I think really was a great talk.
Okay.
Rhonda's got a question, and then if you guys have questions, go ahead and shoot them into chat. We're getting close to the end of the hour, so ask now or keep your peace.
So if you have a patient who is already has a history of the opioid abuse, and then they have a trauma or a surgery, how do you prescribe there?
Yeah, so then you have to be really careful. So let's say if there's somebody that's already on buprenorphine or Suboxone, you could dose it differently or increase the dose for surgery, or even like the methadone is obviously another option, which we didn't talk about. But those patients should still definitely be treated with pain medications, with opioids. And it's just really education and being careful. They're at higher risk of relapsing and making sure that they're only getting a week at a time. But I totally think that, those patients sometimes get undertreated. And so if they're undertreated and they don't get the pain medicines that they need, then they may relapse because they have to go buy on the streets in order to use. So, treating people with opioid history with opioids is okay to do, but you just need to have very close follow-up.
And actually, Randy Brown, one of your departments, talked about this a couple months ago. He talked about prescribing in this context, how to prescribe for those chronic opioid users. So if people are interested, there's a whole nother hour available out there. This hour is wrapping up, and I just wanted to let people know that just because our 7 sessions of spots have concluded, that does not mean that we are getting out of this space. Saferopioids.com is coming soon. It will be a home for all of the content from this session, all of these sessions, along with all sorts of new information about opioids that is, we're going to try to sort of keep track of the current state of the art, and that'll be a resource page for both providers and patients, and just members of the community who want to know more about the opioid crisis. So look for more news about that. If you are interested in the stuff that we've been doing here, the Surgical Collaborative of Wisconsin does have an opioid initiative around reducing prescribing for to sort of minimal necessary levels for a variety of surgical procedures. We do run these other echoes. Randy Brown runs one in chronic opioid use at the Department of Family Medicine, and then we do pediatric emergency care and surgical care for kids. And you can find out more at those websites. And then I do host a podcast if you're interested in hearing more of my voice. That comes out every couple of weeks. It's called The Surgery Set. So I want to thank Dr. Miller. Thank you so much for joining us. I think this was just a wonderful capstone to what has been a great 7 months of this program. And thank you so much for taking the time to join us. And thank you to all of the rest of you who joined us online. And tell your friends to go and watch this as a recorded session in the future.
All right, take care.
All right, thank you so much. Thanks everyone for joining us. And we will see you on the internet. Take care.